You're going to need Jamie's mindfulness session after lunch, aren't you? I can tell. Our clinician panel is... sorry, let me just get myself organised here. So our clinician panel is Stephanie Charnock, who is a dentist practicing at the dental hospital. Belinda Petrovska, who is an oral health therapist. David Butler, who's Principal Oral Health Advisor at the Dental Hospital, and Martin Hall, who's Chief Oral Health Advisor. Please welcome our specialists, our clinicians, who are suddenly not feeling relaxed and comfortable.
No, I could do with another 10 minutes of meditation right now.
Yeah, I thought you might.
Give us some time.
That's not a good news story I just heard. It sounds like a charity service, something out of the Victorian age. We should be grateful for what you get, and we just do patch jobs, and fillings fall out, and there's not much quality improvement, and there are 22-month waiting lists. Sounds great.
Me?
You're the Principal Oral Health Advisor, Mark.
Yes. Look, we've been learning about leadership with humility, and hearing things like that is a humbling experience. We wouldn't hope that everybody had the same experience, but I agree that if there's one person giving a complaint, there's probably 15 or at least behind that, and that it's not something to be dismissed. And I really think that we saw that cartoon from Lynn that said, with all these doctors looking over the bed saying, you know, dentists know best, just qualify that. And we need to move away from dentist knows best to really listening. And listening is time, and we have we measure and we measure and we pay on outputs at the moment. This is why value-based healthcare is such a relief for us as dentists as well, because we're going to move to outcomes. And the outcomes require listening. They require individualised management plans. They require us to actually consider what our patients value and then work on that. So I think the future is positive.
I think that one of the issues you have in a conversation like this is obviously there's 500 people in this room who all believe, and they don't go to work each day to do a bad job. No. They go to do the best job they can, and if they're not doing the best job they can, it's not their fault, it's the system's fault. So this is not the fault of individual clinicians or office managers or anything like that, it's the system. So Stephanie, tell me about how this system needs to change so the people in this room can deliver the care that they come to work each day wanting to give. And what we heard from the room there was that the hospital is probably not too bad, but community clinics may leave something to be desired. May.
Okay. So I'm a dentist currently working in primary care at the dental hospital. So we're providing general care and emergency care. And our current system at the moment is very much focused on seeing as many patients as we possibly can. So there's a lot of emphasis on volume of patients that we're seeing. So it doesn't give us much time to be able to connect with our patients. So it can feel quite frustrating, high pressured. So I think in terms of changing the system going forward, it would be fabulous for us to be able to really have the time to be able to listen to our patients, to actually understand what their preferences are, and to really be able to connect with them so that we're able to support them to achieve those preferences and to achieve those goals. And certainly for myself, that would give me a high level of job satisfaction to feel that I've been able to really make a difference for my patients and help them to achieve those things.
So do you believe that so once you open up that conversation to expectations, well, the expectations would be, I can't get a job because my mouth looks so bad. Mm-hmm. I've got to have, I want to improve my dental appearance, my general dental health. But that might require technologies that you're not allowed to use, or are there other? The question is, are you restricted by protocols that you don't actually have the clinical freedom to do what you need to do for that patient to deliver their expectations? And does the system have to change in terms of providing that?
Yes, I think certainly in the future and where we're heading, following on from Deb's presentation, is that we're going to, as clinicians, be supported to, we call it scope of practice, so actually be able to work to the top of our scope of practice, which for me means being able to provide the care that the patients would want, to be able to go to work, feel confident in that job interview, rather than sort of focusing on the drilling and filling, which is traditionally what dentistry has been all about.
So if you were to work to the maximum of your scope of practice, what would you be doing? Implants? Complicated bridge work? What are you talking about?
Yes, so as a dentist, I am able to do bridge work, crowns, and that's something that maybe we're too quick to refer to specialists at the present situation. So certainly some of that treatment, if we've got the systems to support us, we would be able to provide in the clinic.
And in theory, these devices, I mean, if you look at the private sector in Australia, in the non-dental sector, the private sector overpays for devices. So you'll pay far more for a pacemaker or a screw or something like that in the private sector than you will in the public sector. You can drive down prices. So I assume that in the public sector you should be able to provide crowns, bridges and things at rock bottom prices, because you're not paying the margins that you pay in the private sector. In other words, it's not $1,000 for a crown in the dental hospital, I'm assuming.
The laboratory costs are the same, whether you are in private or public.
But the markup's different.
What we're going to assume in the future is that the value equation would come into that. If we have a filling that keeps falling out, that's failed over and over and over again, then that's a cost to that. It's a cost to the person that has to come in each day and do that. It's a cost to the system. And if a more costly procedure was done in the first place that lasted over that time, then the value equation comes in the positive. So if we start looking at things in value, then that type of high-level care is possible and acceptable within the public system. There's misconception that that's not available in the public system, and some of those what we heard before about the quality of care is disappointing in a way, because there's no reason that high quality care isn't provided in the public service. There's no real clinical restrictions on what can be provided. It's just how that's managed within each of the community centres. And if we apply the value formula, then they will become possible, they will become discussed, and potentially you won't have to keep coming back and you won't hear those stories.
Belinda, talk to me more about this working to the full scope of your practice.
So I'm an oral health therapist, and as a part of my training at La Trobe University a couple of years ago now, they introduced a new course where it was called the Adult Scope of Practice, where I could do what I usually do, which is treating children and doing cleans on everyone else, but also doing simple restorative kind of work and other things on adults as well. So, for example, if I was to utilise my full scope, which I am not at the moment, it would free up a bit more of the dentist time to do that more high-value, complex treatment that's required. So I'm able to do, let's say, for example, about 70% what a dentist can as well. So I can do it just as well as they can. We've had very similar training, almost the same when it comes to doing a filling, whether it's on the biting surface of your tooth or something else like that. So by me being able to treat everyone else and do that kind of things, and also provide you with some more education and some information about just being able to take care of things, so whatever we're doing actually lasts you a very long time, that will free up the dentist for any complex things that you may have to have done, like whether it's a root canal, maybe taking out a tooth, like a wisdom tooth or something like that, that's giving you grief, or whether you need some crown and bridge work or wherever that may be.
So what's stopping you working to the full scope of your practice now?
I think maybe at the moment, because it's still relatively new, is probably people's understanding of what my capabilities are.
But in New South Wales, they've been doing it for years, and in New Zealand, they've been doing it for years.
See, that's where I don't know much about either. So it's a bit of just finding our feet and figuring out how we can all work as a team together, better communications. Because at the moment, when we first started doing this, Steph was like, oh, I didn't know you could do this and this, because if she did, maybe she could better plan her time and my time so we can cater to our clients' need to the best of our ability.
There's a thing in mental health called single session therapy.
Yeah.
And single session therapy is, so you can, cognitive behavioral therapy, traditionally 6 or 13 sessions. And what they found was that people would come for one and not come back. And they thought that was because clients were pissed off and they didn't like what they got and they didn't come back. But when they actually followed them up, they said, oh no, we got what we needed from the single session, we got the message, thanks very much, we don't need to come back. And it changed what they did to saying, well, in fact, so single session therapy now is about, imagine your client is not going to come back. What do you need to do in that thing? So do you believe that you're making the more, if you got to the full scope of your practice, does the initial consultation change, that it starts to become therapeutic rather than just diagnostic?
Yes, I think it would, because obviously every client that comes in to see us are coming in for a reason. Whether it's they're having pain, they don't like the way their front tooth looks or whatever it is. So yeah, we do want to address that, and then we can give them some, because we're looking at everything as well as a whole, we can say, yes, we'll fix this, we'll make you comfortable with that, but maybe you should also probably think about these other few things that are also occurring in your mouth, and we can tend to them as well, but maybe we can't tend to them right now because you're not ready for that.
David, we talked a lot about holistic care before today and during today, and you've got somebody before you who may have diabetes, they may have complex home circumstances, all sorts of things that affect the outcome of care rather than just the technical quality of what you do as a dentist or an oral health therapist. Yep. How best to deal with that, which is what Martin was kind of alluding to earlier, is how best to actually integrate general health, mental health, social circumstances into that consultation, because you could do the best treatment in the world, but if you haven't actually sorted out the other stuff and their influences, they will bounce back or not be happy with the care they got.
Thanks, Norman. Well, first of all, I just quickly like to say, I found the panel discussion from consumer very beneficial, and I must admit...
You must be a masochist.
No. I think it's sort of cemented in my mind. I would have heard the same thing. I've been in dentistry for many, many, many years, probably longer than anyone on this panel here, but I've heard the same message, and that's exactly why Dental Health Service of Victoria, the board, CEO are driving this hard, because it needs to change. If those stories would be the same in 10 years if we didn't do anything, and that's exactly why we're doing it. It's not a quick fix, it's not open the door on Monday morning and we've got the answers. It's a transition, and I think we've all got to recognise that. And I took on board what the consumers said, and I've heard that, in my practice, both private, public, over many, many years. So I welcome that, and it just cemented even more in my mind that we're going down the right path. But it isn't a quick fix. The public sector, years ago was struggling. It's improving now. But I really feel there's a mix between, when I talk about a transition, it's just the comment about the lost filling. Now, for instance, in a transition to value-based healthcare and cost, Martin alluded to it. It may be that you use an extended scope practice to look at it. It might be that in the new with looking at the value equation, I'm involved with technology and equipment advancement with the hospital. It might be that that the upper and lower teeth are scanned. So it's looked at. It's a high risk tooth. If you do a normal filling, it's going to fall out. So you go straight to a more cost effective or the value equation restoration, so it doesn't fall out. So that's where we're moving to, but that's just not a click the finger and it's going to happen. So there are a lot of facets to the value-based equation and the value-based healthcare and the transition. And it's an evolving thing. We may never ever get there. As dentistry's moved over the last 40 years in my time, it'll continue to move. So I think value-based healthcare, we're always going to be chasing it.
I'm missing something here. I mean, so I kind of understand what you're saying.
Yep.
I kind of understand it in the context of a structure of a specialist hospital, like the dental hospital. But I'm coming to work every day in a community dental clinic, which is, freestanding in a sense. Well, how does my day change? I'm an oral health therapist, I'm a dentist, coming to work. How does it change for me? Because I'm coming back to this principle that I explored with Lynn, the Michael West idea that, it's not just Michael West, is that if you have happy, satisfied staff who talk to each other and care about each other, who feel they're all doing the work to high standards, you will actually get better care for consumers in the end. How does it change? Let's put aside the dental hospital for a moment.
Yep.
Let's look at the distributed public dental system in Victoria. Yep. How does it change?
I feel that once we move down this pathway, or are moving down the pathway, that coming to work each day, you'll feel more supported. It'll be a less stressful environment because, let's face it, it is a stressful environment, and we've already talked about that and ways to alleviate that. It'll be more rewarding for the whole service. So it'll be satisfying. I think if we look at holistic care, it'll be, when we talk about supported, it'll be supported not just in the oral health arena, it'll be supported in the greater health arena. So when they come in and look at lifestyle risk, we're looking at risk assessment, looking at lifestyle and lifetime factors, because quite clearly most of the oral diseases we're looking at are chronic in nature. It's what we do, daily home lifestyle management, whatever we put between our lips, whether it be sugar, whether it be tobacco, whether it be alcohol, or hopefully a toothbrush twice a day, makes a huge difference on our oral environment, and we've heard that the mouth's a mirror of the body. So now, the reasons for doing the mix of those is not just go away and use a toothbrush and don't smoke and don't do that. There are a whole lot of impacting social issues and lifestyle issues that in a lot of people we see, the at-risk population, are at risk. And the oral health environment is a low priority. A lot of them are just happy, having a bed each night, having a sleep each night, or putting food on the table, or keeping their child quiet at night so they can get a good night's sleep. So we've got to put that into context. So we look at holistic. They might be sick with diabetes. They might be struggling with that. So we've got to look, why is their mouth falling apart or not to the level we'd like to see it? There are a lot of other impacting factors. So once we start to get that information from an individual or a family, they feel respected. They feel a friendship coming through. They feel an empathy. They feel a humility. This person is not just looking at my mouth. They're looking at me as a whole, as a person, and respecting that and marrying up the treatment they're doing in their mouth with my lifestyle. When I go out of here, I feel like I've got somewhere. They're doing something that marries in. They understand that I might be struggling.
So speaking of marrying in, what's the work that needs to be done? Maybe I'll come to you, Martin, on this. To integrate to the rest of the healthcare system so that you're not just sitting out there on the periphery somewhere?
Just divert a little bit. What worries me about the current system is the inequity. We heard that people have difficulty getting into a system. People are judged by their mouth on their, they're judged on their mouth. It's an indicator of socioeconomic, it's about poverty. We at the moment see roughly about 30% of the eligible population, and we don't have resources or workforce to do that. What David is saying, the key to a lot of oral health is self-management. The interconnectedness with the other health service, other parts of the health service is really important. We need to work with maternal and child health nurses. We need to work with hospitals and maternity services starting early. We've got preschools, schools. We need to actually get out ourselves and make those relationships, not just with the consumers of our care, but more importantly the ones that don't access our care, so that we learn from those people what's wrong with our system. But also we need to establish relationships with the other health services so that they can provide some of that basic understanding and oral health, we call it oral health literacy, and so that that information is provided external as well.
So Stephanie, going from a high stress environment to a low stress, much more satisfying one, just talk to me a little bit more about that pathway and what changes.
So I think whether you're a clinician working in the dental hospital or a clinician working in one of the agencies and one of the community settings, really in the future it's going to feel a much more calm environment, that the care we're providing is much more coordinated. I think really the aim is for clinicians to be coming to work feeling happy to be there, feeling motivated, enthusiastic, and sort of excited to learn new skills, and feeling like there are opportunities to develop those new skills so that we can provide the care that our patients are really asking us to provide for them.
So the whole demeanour of the clinic changes.
Yeah, and that as a team as well, that we're able to work well together, sort of utilising all the different scopes of practice, and so that we're more systematic in our approach.
So Belinda, even though the system will always be under pressure, you'll never be able to provide enough services that's required. There will always be waiting lists. But the minute you walk through the door, it's a bit like Doctor Who's TARDIS, that it becomes calm, because this pressure, we're not dumping this pressure on you, the patient. We're going to give you the care in a calm environment and do the best we can, rather than feeling rushed or pressed. I mean, that's one of the things, it's not the only thing, but it's one of the things you're talking about.
Yes.
So it's a very different atmosphere that you're looking to create.
That's right.
Any final points, Belinda?
Final points. When I first got put into this project, I was very hesitant. I wasn't really receptive to it. I was like, what's this, another restructure? We've been through one already. What's this one gonna actually be? And as being part of it, I think this change is a positive one. I think that, it'll make the environment a bit more calmer for us as clinicians, and we're going to be able to be more confident in what we're able to do, and not have to constantly keep double checking with 3 different people to see if we're on the right track, or I've seen this condition once before, this is how we was treated before, it's presenting the same way, I should be able to do the same thing again. Shouldn't have to jump through 5 or 6 different hoops just to take care of one. Again, that's taking value out of my time as well.
So it gives you a clinician more control.
Yeah, that's right. And also by being able to engage with our clients a bit better, we're going to be able to get to the root of why has your mouth gotten to this point, or what's happening in your life that is preventing you from having good oral health. And then together we can work to improve that, and hopefully not just improve your mouth, but improve everything, because we do already know that there's links to bad oral health and cardiovascular disease, for example. So by doing that, maybe we can reduce different health issues as well. So just holistically, the way David's saying.
As they say, eat your heart out. David, final comment?
Just to comment on, you say, look, the demand's not going to get any smaller. The demand's always going to be there, but I feel that the way going down a value-based healthcare, with using the value-based healthcare principles in encompassing them or integrating into our model of care, is the way to go. So if we look at our ratio of, say, 1 to 15,000 eligible, one dentist per 15,000 eligible population here in Victoria, well, if you go to the old model, which is, I always say, people hear me, I've said it before, a bum-on-seat model, you have to see them, it's not going to work. It does not work. If we look at the holistic team, the broader team, where electronic contact, call centre, post, apps, you name it, looking at risk assessment, holistic risk assessment, lifestyle risk assessment, that's the model we're looking at. That's the value-based healthcare, and it's all around risk, and we manage our at-risk population, because that at-risk population is not getting small. We've got an ageing population, we've got global stresses right across the world, and here in Australia we've got unemployment, We've got upstream issues impacting all the time, which we don't have any control over, but we can look, engage the consumer, risk assess them holistically, respect them as an individual and treat their mouth as part of their lifestyle, as part of the rest of their body, and get some outcomes and feel quite satisfied with it when we do so.
Stephanie, one of the things that's got to change though is that variation. You know, if you've got 14 times variation in some procedures, some people are doing it too much, some people are doing it too little. It means that dentists and oral therapists are going to have to change their practice because there's stuff you're doing that you don't need to do.
Yes,
Do you think people are open to that sort of self-criticism, that self-examination?
I think it's always difficult to be open to criticism, but
Well, it's really more self-examination than...
Yes, it is. It's being able to reflect on your own practice and the care that you're providing and the care that you would like to be able to provide. And I think looking at it from a team approach to be able to improve our efficiencies in terms of delivering the care and being able to provide care that's of high value.
I'd just like to say I know you as a profession, and I know that everybody comes to work to do the best they can. Now we've got I'm a sailor and I like to talk about boats. So if we think about our system as a ship that we have to turn around, well, there's 500 members of that crew that are on board the ship are here today. And we require this leadership at all levels to start turning that ship. And I believe that we will do this. I'm an optimistic person, and I think that the system is giving us an opportunity right now. There's political support for this. The time has come for value-based oral health care. So I encourage you all to get on board and start changing what we heard previously so that this would not be, we don't have to hear that feedback. But
And remember Einstein, don't do
Yes,
tomorrow what
that's
you
right.
did today. Can you please join me in thanking our panel? They thought we were going to have it easy. Now it's time for lunch, and again, keep your ears open for Jamie's call to action after lunch, and we'll welcome you back then.